Okay, I'm Gabrielle Stent. I hail from Nelson and I'm an interRAI educator working with the national team under our umbrella parent of TAS. Just before I start, is everybody here aware of what interRAI is? Is anybody familiar with interRAI? No? Okay. All right. A resident management system isn't new. There's a number of them currently available for use in New Zealand. What I wanted to talk to you today was about embedding interRAI as a patient management system in a small residential facility. When you are a small residential facility in New Zealand and you've got limited funds, how are you going to go about embedding a computer-based patient system? How do you manage your resident management into a paperless environment? And I'm here to share a journey with you that I've taken with a small facility. So my objective this morning is to answer the following questions. Why would a residential facility choose to use interRAI as a resident management system? What did it need to be able to do? How did they go about implementing this and how did we help? And what were the learnings? Sorry, that's where we were. Okay. So I'll back up the bus a little bit and explain to you what interRAI is. For those of you that aren't familiar, it is an international collaborative that has designed a suite of comprehensive clinical assessments. They've been mandated for use in the assessment of older persons throughout New Zealand in both the residential and community settings. The assessments will auto-populate the key information across different care settings, leading to reduced duplication and seamless sharing, which benefits the individual. Outcomes and protocols produced from these assessments support clinical decision-making on which person-centred care planning is then based. So it's a fairly simple concept. So in New Zealand, we have a number of screeners and instruments that are available in the interRAI suite. They were first mandated to use in the DHBs in the community setting in 2013, but most DHBs had been using them for some time prior to that. And it was then introduced into the long-term care facilities, residential facilities, from 2012 and became part of the aged residential care contract in 2015. Those highlighted in pale blue are the assessments that we use in New Zealand currently. The screeners are smaller assessment items that may only have 4 or 5 screens of information, whereas the more comprehensive assessments are listed on the other side. Because it's nationwide, client information is transferable and it's able to be accessed by a wide range of health personnel if needed. For the first time, New Zealand also has reliable assessment data about the health of older people. For those of us that have been around the traps a little longer, back in the days of paper SNAF assessments, it was very difficult to get any kind of data about the older population. interRAI is supported by Momentum software in New Zealand, and as such, a number of other functions are additional to the suite of the assessments themselves. So why interRAI? So the relevance for a small residential facility is now clear, but there are some other benefits for the rest home as well. The software that's already provided to the facility is part of that whole package of the interRAI assessment. They've had to buy into interRAI, it's been mandated as part of their contract, it's all sitting there ready to use. So the only cost to the facility was training time for their staff. It also meant that they could operate a single system for nursing management. There'd be no need to duplicate resident electronic records. Now all staff involved with the resident care could access all of the information. Prior to that, the assessments are completed by the registered nursing staff, so the rest of the staff are now coming on board. The interRAI assessment would no longer be completed in isolation or need laborious printing off in order for other staff to view it. The software capability would meet the needs of the compliance audits and provide a suite of reports required for risk management and quality improvement. Additionally, if other health professionals were to be involved with the residents' care, e.g. the needs assessment service, hospice, allied health, district nurses, geriatricians, they would be able to read resident notes remotely. So the first steps. The first steps were to identify the resources required to enable all staff to be able to report on momentum. How many PCs, laptops, tablets did we need for staff to be able to give timely reports on any given shift? And in this case, they actually only needed to purchase one additional tablet. Then a plan to transition onto the system needed to be determined that would have the least amount of impact on day-to-day business for the residents. It was decided to only implement one piece of the software at a time, beginning with the progress notes. Each staff and group involved in documentation needed training that was kind of tailored to their needs. I was mindful of the cost to the facilities, and so we agreed to target training around shift handover time when staff were leaving or beginning their shifts. Carers were trained and encouraged to use the software immediately. This enabled them to embed the learning, and as other staff were trained subsequently, there was always peer support on shift with using the new software. At this stage too, I'd previously worked with the clinical leads to look at how they were already reporting on paper so that that style that the facility used could be carried over into the software. So I developed with them some daily reporting using a daily report progress sheet. It was drafted in the software to reflect the paper record that the staff were previously using, and it meant that the software could use terminology the staff were used to. The daily progress sheet can be adapted to meet the requirements of any individual facility, and it makes for quick reporting when the resident's stable. Comment boxes allow for additional information, and then additional reporting can also happen in the progress notes. So that's just a few examples there of some of the activities that the person may have been involved with during the day as well. The progress notes, which are in a different screen, have a number of different categories, so you can go through and actually filter when you're going back to look for progress notes by the category of who provided the note in the first place. We also developed a short-term care plan. For those of you who may be aware, a resident does have to have a short-term care plan developed within the first 24 hours of admission, and if there is a self-limiting problem that the person's going through, perhaps they've become unwell with an infection and there needs to be an additional plan of care. So again, the short-term care plan was adapted to the needs of the facility using the layout and language that they were using in paper form. There is an auto-population function so that you can then go back in and evaluate the care that's been provided. The care plan software is not difficult to navigate. It can be educator-led and has an online module available to support learning. Once established, it can be readily evaluated and copied forward, reducing the work for the RN. The diversional therapist is then also able to contribute by completing their activities and socialisation focus into the nursing care plan. So at this stage, the bulk of the education had been educator-led, but there are self-learning tools available within the interRAI suite, and they were also utilised. And again, feedback and evaluation conducted with the facility just helped tailor the embedding process. The wound care module that sits separate from the actual assessment itself was the next to be implemented. This auto-populates the progress notes, reducing duplication for the nurses, and it also provides opportunities for district nurses, hospitals, etc., to access that remotely to provide monitoring and support care. Photos can be uploaded onto this software. As the district nurses said to me, "Oh, it will save me getting on my car and having to get out to the facility." Falls can also be documented and followed up and detailed, and again it will auto-populate progress notes to reduce documentation for staff. And all additional software, the active and recent wounds, falls tracking, active and recent infections, all provide reports that can be used for monthly in-house risk management and quality improvement initiatives. Probably a little to see the detail there. So where to next? When I spoke to the clinical manager last, I reminded her that I was going to be doing this presentation today. Her response was, well, people need to know about this. The more I use it and the more I get my head around it, it just makes life so much easier. We've identified opportunities for more self-learning modules, possibility to enable facilities to drive their own program with educator support as required. Other software enhancement ideas have been raised and been put forward for further discussion with interRAI New Zealand, and opportunities for further connectivity between facilities and other health professionals definitely exist and are an exciting possibility going forward. Thank you.
Pass that along to
Hello, my question is regarding the AI and ethics session. I was fortunate enough to be in the UK where there was a lot of, it was a future fest run by Nesta. There was a lot of discussion on the need for independent review of the algorithms as a way of ensuring that citizen voices are brought. And you brought it up in your talk. Are you aware of any professions or any work done in current AI context where this transparency and review of algorithms body or as part of the regular?
So it's a little hard to hear you, but I think you were asking if there's been any public engagement around that. Is that what you were asking?
Yeah, or as a practice, do you see whenever AI algorithms are deployed and prototypes, etc., the transparency, the review of the code and an independent check, a QA kind of mechanism being in practice, or talk about it?
So I, in the health sector, which is the area that I'm primarily engaged with, there's a push to have a specific ethics committee that would overview any use of AI in the health sector. At the moment, there are 4 ethics committees that oversee health research in New Zealand, but none of them have a specific expertise around data use, basically. So that is something that we would be hoping that the Ministry of Health might become engaged in. And I think I mentioned also that the Stocktake report is also seems to be supportive of establishing some kind of oversight, ethical oversight in New Zealand. But I think it's quite difficult when we're even in the health sector. It's not going to be an easy thing to do, but I think we need to keep progressing forward in that direction.
Can I also ask a question for Cheryl? I'm on a lot of ethics committees back in Australia, so I can understand what you've just said, because it feels like we're 2 yards behind with where AA is. But I had a question about the example you used in London, where the hospital shared their information.
Yeah.
From my understanding of the law, it is that if the patient could expect their data to be used in that way, you can. So could you imagine a time in 20 or 30 years' time where the law doesn't change, but it's just expected by patients that their data is used in AA systems? Because I've heard a lot of examples here, but also in Australia, where AI is being used without consent, And it seems like it's going to come up against that barrier that because patients don't expect it, it does fall foul of the privacy legislation.
I think that's a great question. And I think the issue of trying to consent 1.6 million patients is obviously extraordinarily difficult. The New Zealand Data Futures Partnership here has done a lot of work in ways in which you can gain a social license. So if people do expect that their data will be used in that particular way, it might arguably be seen as kind of the equivalent of consent. But it comes around about the expectation, what do people expect their data is going to be used. And some people would be surprised to know that it's not being used in particular ways. So I think that's a great question, and I think a lot more work needs to be done on getting a social license for these different uses of data.
I'm from primary healthcare. Do you think with a younger generation, sorry, this question's for you, with the younger generations being so involved in their social media and sharing stuff and what have you, that the values in society shift in time anyway, and that therefore the expectations are different and consent is, the meaning of informed consent shifts, and therefore we can utilise the data as is with the current legislation?
Yeah, I think that's a distinct possibility, and I think the social license also isn't static. It's going to be fluid. Some people, I read an article where someone had conceived the futurescape to be where everybody has their own personal data vaults and nobody is allowed access into them, including the government, unless they're granted that access, and we get specialist digital courts that resolve any issues, and independent people who look at the way in which the algorithm's going to impact on society. So, I mean, I guess it could go either way. We could have these individual personal data vaults, but you know, that's what engaging with the public is about, and finding out what the social license is that we can do with the data. So you've got ethics on the one hand, which tells you what you should be doing, and the law, which tells you what you must do, and then you've got the social license, which is what people will basically allow you to do. And they all hopefully will intersect together, and then we'll get some great use of AI.
Yeah, hi, just a question for Bev actually. I've still got quite nightmarish images in my head about scanning. I'm glad I didn't have that job. Did you consider, instead of scanning the records, going for a fully electronic health record instead? Going straight to there.
You clearly haven't worked in the hospital environment or the DHB environment. I think it's a very complicated area, and at the moment we're actually providing one virtual solution, if you like, through a portal, actually accessing several different vendors' products and increasing the individuality of the number we look at. And so that's the first point. The second point is the Voyager discovery led us to know that there are actually at least 12 or 1,200 different types of document used for all sorts of different things. Some are graphical, some are tabular, some are written, and so we're in phase one of that recognition journey. Which things will be amenable to the core medical record? Clinical notes is an obvious one, which is handwritten and can't even be scanned by the intelligently. So maybe that's what we tackle first, and actually then there's another driver. What can you do on a ward round so that becomes completely electronic? So there's different lenses you can put on how we want to move that journey forward. Now we understand the problem better. So I think it's a stepwise thing.
Oh, thanks.
This question for Bev again. So an issue we have come up frequently at Cape Coast, and Scott might be able to comment on this as well, is with more records being uploaded or added to patients' record, trying to find documents, clinicians having to click through lots of folders. We were simple folder structure. The search function looks good. Have there been any comments or feedback on how else we can better identify key documents?
So I think for us, the metadata is really important. So if you know us, so I think there's two ways of looking at it. So there are two different broad ways people want to look at stuff. One is horizontally, one is vertically. So some people might want to look across an admission just to track really what happened during that whole thing across lots of disciplines, documents. An anaesthetist or a surgeon might want to look vertically at everything to do with an operation, breast cancer for instance, or an anaesthetic that was given. So it's trying to recognize firstly the different ways people seek information, And we're, if you like, in our example, we're scanning each admission as a block, so you can work through that way. But if you're looking for ACC and revenue, you can type in ACC, and it'll pull out every ACC form, so the coders and the money makers can check on that. If you're an anaesthetist, you can type in anesthesia or anaesthetic, and it'll pull out the anaesthetic record. So we're at phase one of that, but actually embedding as much metadata as we can, and then being responsive to what else is needed. And that's why once we've implemented the new front face, if you like, we're starting on the clinic visits to try and understand exactly how do people will want to reference the data. Second point, which I didn't mention there, is example in primary care, we went notes-free in 1994, and actually we had lots of people you need to change management on, and after about 2 to 3 months of having in the UK 18 sets of notes every morning and every afternoon sitting on your right-hand side or left-hand side, depending on which way you practice, we ended up saying, why have we got all these notes here? We never use them. And then there could be a recall very quickly when we did, but actually there's a natural evolution of time. And if a whole bunch of patients may take longer in secondary care, if actually 15%, 20%, 30% of your frequent flyers have already touched the hospital within a certain time, you actually then don't need the paper records, or you shouldn't be needing the paper records because they're irrelevant. And then because you can seek the information. So we're not consciously now going for a back scanning whole of record. We're looking to a prospective evolution out of paper because people just don't need it anymore.
Just a quick question about your search function as well. Does it look across all your, so it looks through your e-record, but your discharge summary clinic?
No, so unfortunately that's in a separate system at the moment. That's in our Health Connect South portal. I suppose for us, we're trying to add enough metadata that one day when there's a valid home in our portal, we can migrate stuff through. So, Martin disagrees with me on this, but actually if you had a cardiology outpatient letter from Hamilton, we would like to say, Health Connect South Concerto has a place for cardiology outpatient letters from a secondary care institution. Let's put it there. Not in e-records. So it's probably as much about functional groupings where people expect to find. So your question, my question to you as a clinician, where would you expect to find a cardiology outpatient letter regardless of where it came from? Let's label what we've got now so that we can move it to that expected place when we can and how we can with agreement of our clinical teams.
Just kind of a point to kind of make around kind of e-referrals and e-platforms and things like that. I think from a junior doctor perspective, I think you can be guilty of creating immense amounts of lists of kind of electronic referral pathways and things like that that actually really and platforms on platforms on platforms and portals within portals. I think, as the clinician on the ward round, when I want to write an kind of clinical note, it really needs to be it needs to be quick and intuitive and really upfront, otherwise no one will use it. And that's kind of that adage of, change culture is probably the most difficult thing out of all of this. I like to think of it as kind of having a pigeon in your hand and trying to throw it across the room onto the rubbish bin over there. You can kind of predict what it's going to do for that first little bit, but then it flies off somewhere else. And so sometimes engaging the sort of the lowest common denominator, the end user, that really junior doctor or that really junior nurse or that allied health individual from a really junior perspective who use these kind of tools and these platforms that we look at is probably the key to success, really.
Bev, I know it's Northland. The not-for-scanning pile was very impressive. How much of your business case benefit would have been achieved by dumping paper needed filing in the first place?
That's a really good question, Alan. I think the business case, not so much for e-records, more for things like our e-observations, patient track, nursing tools, just because you're then not needing all the nursing observation charts. In retrospect, it could have been used as part of it, but I think, in a sense, that was a problem that would quite quickly go away. In fact, that actually added to the unknown of the business case that we should have written but didn't, which was the poorly prepared for volume of stuff that we didn't want in the first place. So that was more an omission from a business plan because we didn't scope it into what we thought. We hadn't thought about it enough, basically. We hadn't understood the problem we were trying to solve before we then tried to solve it on the fly. So it wouldn't have appeared in the business case, but would have been a good lever for time and efficiency and universality of where things live in a record.